Good evening, everybody. At the outset, I would like to thank the organizers for giving me this opportunity to speak. The topic allotted to me is next level follow up of kidney transplant with donor derived cell free DNA and gene expression. Our current approaches towards assessment in the post transplant period are multidimensional DSA to provide clinically relevant information with respect to the prediction of allograft injury and loss. In the post transplant period, what one is really looking forward to is a non invasive tool for clinical decision making and which can form the basis for targeted therapies. Biomarkers are much needed for post transplant surveillance in solid organ transplantation. What we have now is lifelong immune suppression drug regimes, which are mostly one size fits all. The current transplant surveillance options available to us have limitations. We have the serum creatinine, which is not specific, not sensitive, and may increase only after significant kidney injury. The DSA has a poor positive predictive value for ABMR, and surveillance biopsies are invasive, not without complications, and there are interpretation challenges. Immunosuppressive drug monitoring can act as a surrogate marker for rejection risk. But what we have as of today, a non invasive, more accurate biomarker is the donor derived cell free DNA. The circulating donor derived cell free DNA is present in the serum, plasma, and all body fluids. It originates from cells which are undergoing either apoptosis or necrosis. And what's important to remember in donor derived cell free DNA is that it is cleared from the blood by the liver or the kidney with a short half life of 30 minutes. The concept of donor derived cell free DNA is levels can be measured in plasma and increase as cells from the transplanted organs are injured. Like I've said earlier, released during apoptosis and necrosis. The technique employs targeted amplification and sequencing of the single nucleotide polymorphisms to quantify donor and recipient DNA contributions. A large number of studies have worked on the steady state of donor derived cell free DNA post transplant, and for kidney, the values range at 0.3 to 1.2%. Donor derived cell free DNA in transplantation can discriminate active rejection from no active rejection. It is more accurate than serum creatinine in diagnosis of active rejection, highly sensitive in distinguishing ABMR from non ABMR, and in drug monitoring. So, donor derived cell free DNA is a non invasive test of allograft injury that may enable more frequent, quantitative, and safer assessment of allograft rejection and injury status. This, by and large, fulfills most of the criteria that have been laid out for an effective biomarker. Looking at the DART study, which is one of the largest multi-center study which has been carried out in donor-derived cell-free DNA, it establishes the relationship of donor-derived cell-free DNA with acute rejection. It compares the performance of donor-derived cell-free DNA with serum creatinine. It determines the ability of donor-derived cell-free DNA to discriminate active rejection and also discriminate ABMR with no ABMR. The study looked at samples with increase, that is more than 1% donor-derived cell-free DNA, and these occurred significantly more often in the following types of rejections and sub-elements of rejection: the active ABMR, chronic, acute ABMR, moderate microvascular inflammation, presence of DSA, and C4D staining. The median levels of donor-derived cell-free DNA in patients with active rejection was significantly higher at 1.6% than in the comparator group, which was without active rejection at 0.3%. Also, they found that the median levels of donor-derived cell-free DNA varied with the type of active rejection. No doubt they were the highest in those with ABMR, and then almost normal with the TCMR rejection types. When looking at the ability of the test to discriminate no active rejection from active rejection, the donor-derived cell-free DNA was way above 1% in those who had active rejection features as compared to the no active rejection features. When they looked at the similar group with no active rejection versus active rejection with serum creatinine, there was hardly any difference, which was noted between the two groups. Looking at the significance and the high sensitivity of the donor-derived cell-free DNA in distinguishing ABMR from no ABMR, they looked at a cell-free DNA threshold of 2.9% and 1%. At 2.9%, patients who were DSA positive, the positive predictive value of distinguishing between the ABMR and no ABMR group was 89%, whereas it was 81% when the values were taken at 1%. Now, if you look at this, the ABMR group, the values here were far above 2%, it was almost 2.9 or 3%. The DSA positive, no ABMR, the values of donor derived cell free DNA were well within normal limits. And when it was DSA negative and cell free DNA negative, they were again within well with less than 1%. So this study concluded that the combined use of donor-derived cell-free DNA and DSA testing may improve the non-invasive diagnosis of active ABMR in kidney transplant recipients. Now, this again highlights the 89% positive predictive value of the test AlloSure in detecting ABMR in patients who were DSA positive. But what's even more significant as far as donor-derived cell-free DNA is concerned, that it has a very high negative predictive value. It can help rule out rejection. A normal donor-derived cell-free DNA actually implies that there is no rejection. So 95% negative predictive value for active rejection with a sensitivity of 85%, specificity of 33%. When looking at donor-derived cell-free DNA and its use in monitoring rejection treatment, this study by Brennan et al. Highlights very well that it may be useful to detect and subsequently assess recovery from acute rejection. Now, the active rejection, when it's present, the values of donor-derived cell-free DNA well above 1%, which is the cutoff. At 1 month after treatment, while monitoring for treatment for rejection, the values fall to below the normal levels and fall further at 2 to 3 months. So they concluded that the levels of donor-derived cell-free DNA are elevated at the time of rejection and decline over a period of time up to 1, 2 to up to 3 months. Another conclusion here was that rebound increase in donor-derived cell-free DNA post-treatment is a poor prognostic indicator for the graft outcome. So that's how one would monitor with donor-derived cell-free DNA, routine surveillance in the post-transplant period. If rejection is picked up, treatment for rejection instituted, and then following that, the monitoring for the treatment for rejection. There are also studies, more recent ones, which have studied the impact on outcomes with de novo DSA. Now, Jordan et al. Highlighted that the donor-derived cell-free DNA initiates de novo donor-specific responses, and this was also part of the DART study. They found that higher donor-derived cell-free DNA levels are associated with de novo DSA formation significantly. Now, and Gaurav Gupta et al. In their study concluded that high donor-derived cell-free DNA levels predict development of de novo HLA antibodies after kidney transplant. And this shows the two groups where DSA, donor-derived cell-free DNA, was greater than 5%, and this is the outcome when it was less than 0.5%. When you look at the RADAR study, they worked at the And the summary there was that donor derived cell free DNA may risk stratify patients with borderline TCMR identified on biopsy. So the patients who had donor derived cell free DNA of greater than 5% were at an increased risk of EGFR decline and greater presence of DSA and recurrent rejection. The RADAR study suggests a new standard for assessing donor derived cell free DNA levels and reinforces the importance of monitoring changes in the donor derived cell free DNA levels over a period of time. Donor derived cell free DNA as a surveillance test to determine active rejection is early detection and upfront clinical intervention, prioritization of invasive procedures, and also Center for Treatment Responses and Patient Compliances. When looking at the donor derived cell free DNA as a surveillance test in various clinical settings, no doubt a very important biomarker in transplant surveillance, particularly for the high risk patients, highly sensitized with high PRAs, also for surveillance for all patients to monitor for any event of rejection that may be occurring. For cause with high serum creatinine, it provides specific information on the type of rejection and treatment follow up or monitoring, which provides information on post rejection management and also may provide information when changing drug dosing. To bring out the significance of donor derived cell free DNA in the post transplant monitoring, case, case study which shows that DSA positive at three time points, MFI of 1900, 1600, and 2800. Donor derived cell free DNA was negative at all these time points. This patient actually would not be experiencing ABMR, and this highlights the high negative predictive value of active rejection. Now, DSA positive on three occasions, biopsy is negative for ABMR on all three occasions, and donor derived cell free DNA has been consistently below 1%. So the patient was not a case of ABMR, but as far as the test or the biomarker donor derived cell free DNA is concerned, it has a high negative predictive value for active rejection. The second case shows the usefulness of the longitudinal monitoring with donor derived cell free DNA. A case study where D plus 145, cell free DNA at 3.7%. Allograft biopsies at day 30, 60 did not show features of rejection. DSA was consistently negative, but at the third instance, the DSA was high, the biopsy was positive for ABMR, and the cell free DNA was skyrocketing at 3.7%. The third case is a surveillance with a case with stable creatinine at 1.6 to 1.7, DSA persistently negative, donor derived cell free DNA consistently high, very high at 5.2% at 1 month, third month, and 4 month. Now, with a stable creatinine, there was no initiation of a biopsy, and what was really missed in this case was a non HLA rejection and had gone untreated for a long time to decrease graft survival. So, no DSA, a stable creatinine, and yet the peritubular capillary infiltration, which was seen on the kidney biopsy, was the only finding which was there when it was finally detected. The testing schedules with donor derived cell free DNA post transplant once a month for the first 4 months and then quarterly. However, the recommendations vary and can be formulated as per the protocols being followed in any institute and modified as per the recipient's requirement. The surveillance testing can also be added to previously established protocols to be linked with serum creatinine, BK virus markers, the DSA, and donor derived cell free DNA. Definitely, it is recommended to have baseline value at 1 or 2 months post transplant and then to monitor and take it on from there at different time points. Other than donor-derived cell-free DNA, we now have newer strategies which are emerging to monitor graft functions, and these involve primarily either monitoring the level of immune system activity, the nuclear factor of activated T cell regulated gene expression, the immune cell function assays, which is the immunocell function assay test, which is well known, urinary or plasma chemokine levels, and cytokine gene expression patterns. Another approach would be to measure the damage related gene expression in the injured or the rejecting organ, and that would be AlloMap, which looks at the immune markers in during rejection, and the K salt. When you combine two techniques to look at the allograft health, and this shows the significance of gene expression profiling along with donor derived cell free DNA. The AlloMap, this looks at signature genes at the lymphocyte activation, cell migration, T cell priming, inflammation, steroid sensitivity, and platelet activation markers. Now, this is a non-invasive test, which, when combined with the donor-derived cell-free DNA, together they can be a powerful non-invasive tool to transplant surveillance. The other test we have available to us, though not in India, is the immunoassay. And this test targets the lymphocytes. There is stimulation of the lymphocytes, magnetic separation of the CD4 cells, and then look at the ATP activity, which is picked up by an instrument which looks at the intensity of light released and by the ATP and detects that. So this test aims or rather targets the assessment of the effectiveness of the immune suppression, which can then be modulated based on the requirement of the recipient. So, as of today, what we have is the power to unlock the molecular window using technology. We have in any test, first the molecular, in any case, first the molecular presentation. This involves changes ahead of other markers, which can be shown in the tissue, blood, or the urine. The cell free DNA at this stage is intertwined with the gene expression profiling that we may have. The inflammatory activation from activated gene expression can stimulate pro inflammatory cascade, and this stage then moves into a subclinical or an intermediate stage, which is where we diagnose or we pick up the donor specific antibodies. The biopsies begin to show features of rejection. Infection screening is done for various viruses out there. And the subclinical presentation, when it moves on to the clinical presentation, that is when there is worsening of EGFR or proteinuria, height, DSA, clinically indicated biopsies may be performed. There will be recurrent disease and allograft rejection. So the spectrum is huge, and the aim is here to pick up as early as possible, which is the significance of molecular testing in transplantation as of today. That brings me to my end of my presentation, and I thank you all, and will be happy to take any questions that you may have. Thank you.